Okay, so if you're just joining us, Sam is here in the chats. You all can go ahead and finish filling out that poll. That is just going to help us to, come up with future webinar topics for you. You can feel free to chat that to us as well or email us here at this website that we have, nursepractitioner@archerreview.com. Also, if there's anything that our team can help you with, from booking a live tutor session to these free webinars to also taking advantage of our free QBank trial. If you're going to be taking a test in the next couple of weeks, I really recommend that. There is no cost to you for that first 7 days. And it has over 1,600 questions. So as we go along in the webinar, just take a look and see what all we have to offer. You can scan this QR code, and we just want to connect with you. We have socials we can connect on as well. And I just encourage you all to take advantage of all that. And I'm so glad that you all are able to join me today. Happy Monday morning. We're going to go ahead and get started on our big three in primary care. If we haven't met, my name is Brittany Long. I'm a family nurse practitioner. And I just want to help guide you through some of these topics as we go along. And, one of the big triads I found that I see in patients most commonly as a practicing nurse practitioner is hyperlipidemia, hypertension, and diabetes. And if you have already done some clinicals, or maybe you have some nursing experience, or you have already are practiced as an FNP, these are going to be three things that you're going to come into contact with every single day if you haven't already. And it's just really good that to talk about the guidelines and know where to find those, and just be able to manage these patients because they can get very complex quickly, and we want to try to capture those roadblocks before that disease process does damage or further damage to our patients. So let's go ahead and get started. We have a lot of content to cover over this next hour. I'm looking forward to spending it with you. Hyperlipidemia is going to be our first topic today out of the three. This is my chart here for normal cholesterol ranges. I didn't make this chart. This comes from our guidelines, but basically total cholesterol less than 200 is our goal. That is an optimal level. Triglycerides being under 150, and remember that's going to be your carbs and sugars. So if the patient has, diabetes or pancreatitis, or, more prone to those things, their triglycerides might be elevated. Your LDL, we want that one to be up as high as possible because that's our good cholesterol. I'm sorry, I've put that backwards again. Your LDL, we want it to be as low as possible. L for low. Remember, L for low. That is going to be our bad cholesterol. We want that one to be as low as possible because, as you can see here, that one is the one that has these plaques in the artery. And so we want to try to minimize that as much as possible. So 100 or less for the normal, average, healthy adult patient. But if they have other things that can put them more at risk for heart disease, like say maybe diabetes, their goal is going to be much lower. It's going to be around 70. And as you can imagine, that's a tight goal to get. So that's kind of where our statin therapy can come into play when getting these patients to goal. And then your HDL, I remember H for high. I want it as high as possible. 40 is the protective number for men and 50 for women, but ideally as high as possible as we can get that. That helps to kind of stabilize some of this plaque. It kind of helps to cancel out the LDL a little bit. And so we want to really encourage our patients in their heart health journey to eat those good fats, engage in regular exercise so that they can get their HDL up as high as possible. So this is just your reference right here on your screen. You can come back to that, jot those numbers down, and as we're talking through, any questions you have, you'll have something to go back to and reference. All right, let's go ahead and talk about types of hyperlipidemia. There is a primary hyperlipidemia type. That one is the one where patients will have like a genetic risk factor, or they'll have like a really strong family history of hyperlipidemia. And we're not going to talk too much about that, but the secondary type of hyperlipidemia is the one that you're probably already thinking about on your mind. That's the one where the patient needs lifestyle changes. They maybe have other medical conditions, like I mentioned, diabetes earlier, or hypertension. or their medications may be also contributing to that as well. So again, just two different types, but the one that we usually think about here, at least in America, is secondary. But again, primary is just as important because these patients may make all the lifestyle changes needed and not really see any results because they have that genetic component with that. Secondary is going to be the one where our modifiable risk factors, such as smoking and diet, exercise, obesity control, that's going to be the one where we can really get the most bang for our buck on those things. All right, so the USPSTF has some guidelines for screenings. Again, they have started screening children as young as 9 to 11 years old because, again, the quicker we can catch these genetic familial links in young children, the quicker we can treat them, either get them to the lipid clinic or, whatever it be, we can check this early and try to prevent heart disease later on and really mitigate that risk. So looking here, you're going to start screening your kids in those middle school and high school age. And then also men age 35 and above with no history. If it hadn't been captured on a screening, we can start there around 35 years old. But again, if they have a history or risk for cardiovascular disease, feel free to get the screening early. Women starting around age 45, but also think about those with risk of coronary artery disease. If they have diabetes or something else, we're going to start that sooner and we're going to check that and make sure that we're not missing anything as far as their heart health goes. If they're low risk, we can repeat this every 5 years, but normally what I'm seeing in clinical practice is we're checking this on about an annual basis if the patient had last year's were a little bit off. They were a little bit high. They weren't quite to goal. We recommended lifestyle changes. We'll usually check this, in about a year if there's anything. Now, the other thing I want to talk about too, back to this pediatrics and back to this slide here talking about primary hyperlipidemia. Who can put in the chat section how you're going to screen for that? So let's say you do have a 20-year-old that comes in there and their LDL is maybe 190, but they don't really fit the criteria for looking like a high cholesterol patient. And you're thinking maybe this could be a familial or genetic link. Do you guys know the test that we can run and go a step further before we decide to either make a referral or put them on cholesterol lowering agents? What do y'all know about that? So I'll give you just a second and put that in the chats before we go on here. Open up the chats and see what y'all are writing. All right, let's see what we got. Okay, so apolipoprotein A and apolipoprotein B are going to be your initial screenings for that. So if the patient comes in and you think that they could have a genetic link or they just really have a strong family history, you can get the apo A and B and check that as well. So for everybody else, if we're thinking more of secondary risk, or the older adults, you're thinking like 40 and above. I have got on here a calculator for you. This is the calculator that you can use in practice. Some of your EHRs even might have this built in. And this is from the Framingham Heart Study here. This came out around 2013. It was updated. It's from the American Heart Association. And this is going to be able where you find your risk, okay? So it's going to be a decision-making tool on whether or not this patient needs statin therapy. So for example, let's say that our patient is a smoker, they've been treated for high blood pressure, and let's say that they have let's say they're not diabetic, but let's say that their LDL is a certain number. You can put all that in and it's going to tell you what it's going to give you a calculation, a percentage, if you will, of whether or not this patient needs to be considered for statin therapy. It's going to start advising you to give statins around 5.5 to 7.5, depending on what else is going on with your patient. But by 7.5, you're going to have to consider statin therapy. So that's what I've got on this list for you here. So again, this is going to give you a 10% as well as a lifetime year risk with prevention measures. It's going to give you, again, guidance as a tool. And this is going to be able to where we can talk to our patient and we can talk to them about their 10-year risk of heart disease. Now, if that 10-year risk is around that 5 to 7.5%, they're going to be in that borderline risk. But right here, when they start getting across that threshold and they're right here at the 7.5, that's where you're automatically going to offer them a statin. So again, down in here is where we want to try to catch them to where they can start making those lifestyle changes and hopefully either avoid a statin or not have to start a statin until later in life, because a statin is pretty much going to be most likely a lifetime commitment for most patients. So just an FYI, if we can hold off because we can get them to do lifestyle changes, that is going to be better for our patients in the long run. High risk, again, if they're over 10%, they're going to automatically be going to a statin, possibly even a high intensity statin, which we'll talk about here just in a minute. So, anyways, just FYI, know your risks, and you can play with that calculator. You can put in all kinds of different things. Like I said, it mentions smoking and age and blood pressure, and it'll give you that that calculation to provide guidance to your patients. So I would just be familiar with that before I went in to my patient room to have a cholesterol talk. All right. The good news about statins is there's only about 8 of them. And the good news is that as long as you know those and you know your dosages, you basically can determine if this patient needs a low, moderate, or high intensity statin. So a couple of caveats here. A lot of people in that range around that 7.5% are probably going to be started on a moderate intensity statin that I'm circling here for you. And you can see these statins can shift in a different direction. So for example, if I say something like simvastatin, okay, 20 to 40 a day, that's a moderate intensity, but you look over here, oh, that medication can actually go down to a low intensity statin. If I also can shift this direction, I can look at rosuvastatin or Crestor and see that it can be in the moderate intensity level, and then it can shift over here to a high intensity depending on my dose. So now who might be an automatic candidate for a high intensity is somebody who either maybe they have diabetes and they have like a really strict goal of 70 or less, and they're really far away from that goal, or somebody who has had a cardiac event. So somebody has had an MI, or somebody has had, some sort of cardiovascular event. This patient is most likely going to be started on a high intensity statin or bumped up to a high intensity statin. So again, their goals are going to be much more stringent and tight than the general population. All right, let's go ahead and take a look here at some other pharmacological treatments. So statin is going to be our first line. Well, really lifestyle factors is going to be our first line, but our second line will be a statin. Our third line options of if we need more things, or maybe your patient doesn't have a good tolerance to statin therapy, or maybe their goal was way off. Their cholesterol, their LDL is 190 and their goal was 70. We might need a little bit extra stuff on board. And so there's some other options here for you that, we can consider. So just kind of have that in your back pocket. I'm not going to read that all, this entire slide to you, but just know that there are other medications for cholesterol lowering agents besides just statins, but statins is going to be by far our first line medication. All right, let's talk about a couple of things that we need to warn our patients for and be aware of when we're starting patients on statin therapy. So normally when I start a new medication on a patient, 9 times out of 10, depending on what it is, I will bring them back in about 4 to 6 weeks, sometimes as little as 2 if it's, some sort of antidepressant or something. But I'll bring them back and have them come back and follow up with me in the office. And I'm just want to have a conversation with them. Hey, how did it go? Did you have any trouble getting your medication? Was the cost okay? Yeah, okay, good. How about your side effects? Did you have any side effects? And if so, what are they? What can we do to maybe mitigate some of those side effects? And then, so I'm just kind of checking with like compliance and medication adherence, barriers to care. And then, as long as everything is humming along good, I'm usually going to send them out the door with a lab order. And on that lab order, I'm going to have like a CMP and maybe a lipid panel for later on down the road, and just check and see how the statin is working with their body. And some of the things that we want to check with, and some side effects that we want to warn our patients, not to scare them, but just to talk to them, and things to look for is things like muscle pain and dark urine. If they experience that, they need to bypass my office and they need to go onto the emergency room to be checked for something called rhabdomyolysis, which is just where literally that muscle tissue is breaking down. Muscle cramps on a statin are common, but muscle pain and dark urine are a serious side effect. So we need to make sure that we let the patients know the difference between those two things, and they're being educated on what to expect. Okay, this is not an expected finding of a statin. A little muscle cramp or a little muscle pain when initially starting might be, but this is not. Drug-induced hepatitis, that's another one. We want to order that CMP. We want to check that about 30 to 60 days after getting on a statin for our patients. And then also just making sure that we're not, getting this. And you're going to see those liver enzymes start to elevate. You might even see some jaundice or abdominal pain. So again, if my patient starts to notice, yelling of the skin or eyes or anything like that while they're taking the statin, they need to let me know immediately. So again, these are two bad side effects of statins that would constitute probably stopping that medication and starting something else, and really close monitoring and follow up. All right, so again, your role as a nurse practitioner, now that we have our foundational knowledge of hyperlipidemia, let's think about what we need to assess in our patients who are at risk for this condition. So, of course, before I even start a statin, I want to get a good HPI, I want to get a good family history, and I want to do a physical exam. Now, I want to know if you guys can put in the chats what physical exam findings you might consider a hyperlipidemia workup. Remember, we don't have x-ray vision. We can't see inside of their blood vessels with our eyes when we're doing an assessment, but there are some things that we might consider before we want to order that lipid panel that we might catch on an assessment. So can you guys list those things that would automatically warrant, hey, maybe it's not quite time for their lipid panel to be drawn, but we want to order it this time because of X, Y, and Z. So what are y'all thinking about assessment findings? So I'll pause just a minute and put it here, let y'all put it here in the chats. Yes, and Sam, absolutely. It's great to get a baseline. And if a patient struggles, really with anything, it's good to get a baseline on your patients. So absolutely, Marilyn, you're on it. That's right. So if we see things like arcus sinalis, absolutely. What about high blood pressure? What about obesity? What about those yellow deposits on their eyes, right? Any of these type of things we definitely want to be looking for on our exam and making sure that we're not missing, so that we know that we might need to order a lipid panel. All right. Of course, your lab work is going to be confirmatory of your diagnosis. And again, if they're over 7.5%, you'll probably start them on medication, or at least offer it to them. And then if they decide they want to recheck in 3 to 6 months, at least document that you've offered it to them, and they're going to do lifestyle changes and see if they're just really borderline there. Okay. All right. So, and remember, your lipid panel needs to be fasting. Okay. And again, we're going to work on the statin is going to be specifically working on the LDL to reduce the cardiovascular risk. All right. So now we're going to change gears. We're going to talk about hypertension. Hypertension is just that fancy word for high blood pressure. And who can put in the chats what is the blood pressure, where we kind of start thinking about starting medication? We'll go through that here just in a minute on this next slide, but I want you to think about this. High blood pressure is deemed the silent killer because, again, we cannot see patients' blood vessels. This is the leading factor in development of cardiovascular disease, and it's high risk for death and disease. So again, oftentimes this hypertension goes unnoticed for years and years, and the damage is already done to the vessels, the kidneys, and they start to have a lot of issues that we can kind of pick up as we go along. But again, initially, it will last for years and years undetected. undetected. So that's why it's so important to get those vital signs on our patients. And if we see that they're starting to kind of creep up and be borderline, we want to offer them a blood pressure log and treatment if indicated. So let me check the chats here. Let's see. What did y'all put? All right, so let's look at our American Heart Association. So American Heart Association has come up with some newer, stricter guidelines in recent years. But we have right here, normal is now less than 120/80. So when I first started nursing school, that was considered normal. Now it's less than is normal. Elevated blood pressure, you can see, and stage 1 hypertension is kind of where we're trying to catch our patients at. If we're starting to see these numbers up in these 120s, 130s/80, we're going to try to mitigate this and have them not go into stage 2 hypertension, but rather start making lifestyle changes right here. This is where they can kind of really get a lot of bang for their buck. Are they walking? Are they exercising? Doing some sort of cardio? Are they watching their salt intake? Are they staying properly hydrated? So again, we're trying to really focus on lifestyle changes when we're down in here. When we start seeing that 140/90 or higher on several readings, that's when we're going to start thinking about maybe this person needs some blood pressure medication. Also, just briefly going to mention the Joint National Commission has JNC 8 guidelines, and these right here are basically a little bit different guidelines. It has even an indication for African Americans, and it also has an indication for people with general over 60 years old, CKD, and diabetes. So again, excuse me. Again, it gives you just a little bit different guidelines, but we are definitely all kind of moving towards the American Heart Association in practice. But again, just be aware that there's more than one blood pressure guideline out there. All right, so talking about starting blood pressure medications, okay? So first of all, you're going to space your readings a few weeks apart. I don't care what their blood pressure is when they come in to see me the first day. Obviously I want it low, but I'm most likely not going to give them medication unless they're here for a blood pressure complaint. I'm going to send them home. I'm going to have them to take that over the next week, 2 weeks, even maybe up to 4 weeks, depending on what that is. And I'm going to have them to bring me back several readings of their blood pressure and what it's been. So again, this right here, home logs, is key. I never will just treat off of just one reading in my office, 9.999 times out of 10. Again, unless they tell me, oh, it's been running high at home, or, oh, I was in the emergency room last week for high blood pressure. Okay. But if they're just coming in for, let's say, strep throat and their blood pressure is a little elevated, I'm not going to start addressing their blood pressure right then. I'm going to look at the trends. Okay. I'm going to send them home with a log, have them follow up again when they're better in a few days, and make sure that their blood pressure is coming back down to normal. White coat syndrome, you guys know that. If I was at Walmart taking the blood pressure, it probably wouldn't be high, but because they're here in my office, they're kind of nervous, kind of stressed, maybe not feeling good, and their blood pressure is going to be elevated. Mass hypertension is that it's good when they're here at the office, but it's high at home. So again, that's something that you kind of want to question your patients. If they're taking a blood pressure pill at home, I'll ask them, hey, can you just keep a log for me? Just a few times a week, spot check it. Make sure it's not spiking up too high, because you can come in here at 9 a.m. and it's beautiful because you just took your pill an hour ago. But what's it look like at 5 p.m.? Does the medication last you throughout the whole day? And so that's something that we don't want to miss. So just kind of checking in with your patients that way as well is really helpful. All right, let's talk about this hypertensive emergencies. Again, we have primary and secondary hypertension, but a hypertensive emergency is just that unexplained rapid elevation of blood pressure. And I tell my patients, anybody who has a blood pressure of 180/110 to 120 or higher needs to go to the emergency room. If they are getting those kind of readings at home, they need to just not come to my office right now today. They need to go into the emergency room, take care of that hypertensive crisis, and they need to come back and follow up with me when their blood pressure is at a safe level that we can deal with. So that is my cutoff. Or if they're having like a lot of symptoms, worst headache of my life, or I feel like a rip gripping sensation in my abdomen, or I'm having a lot of nosebleeds with blood pressures, really high, or I'm pregnant. Those things will go to the ER with a lower threshold of blood pressure, but 180 over 110 without other symptoms still goes to the emergency room. And again, like I mentioned, primary and secondary here, we have, again, trying to make these modifiable changes with primary hypertension or essential hypertension. Secondary is going to have some other cause, drugs. Think about your decongestants, right? Or renal, if they have renal problems, they may have a hard time regulating their blood pressure. So just thinking about these types of things for your patient and what could be the cause of why your patient's blood pressure is elevated. That's all I want you to know from this slide. All right, so you guys know that blood pressure is so important. It regulates a lot of things in the body. It can be tied to this. It holds hands with the cardiovascular system, holds hands with the kidneys. And you guys know that there's all kinds of different assessment findings that we can find with our patients who have elevated blood pressure readings over a long term, a long tracked time of hypertension. So again, one of the most things I'll draw your eye to here is left ventricular hypertrophy. That's something you can see on an EKG. Might even be able to detect it if their apical pulse has shifted. If we're doing a retinal or a optic nerve exam, we can't see the retina really unless it's been dilated, but we can see they should be checking in with their eye doctor, but we can kind of see some of those cotton wool spots, things like that. Of course, in their brain, they can have vascular dementia or strokes if their blood pressure is uncontrolled. And then, of course, thinking about protein in the urine, microalbumin, creatinine ratio for our diabetics. So thinking about nephropathy, and then renal failure, of course, if it gets to be really uncontrolled, long-tracked hypertension, it can lead to renal failure. So again, very important to be checking in on our patients, making sure we're not missing anything. All right, history and physical. This is can be tricky because again, I really only is just going to be measuring vital signs for this patient. I might have some physical findings. So think about like carotid bruits or JVD or their thyroid's enlarged, again, cotton wool spots. But again, mainly I'm going by the blood pressure reading and what they're bringing in from home. So it's really important. I'll have them to kind of bring me their cuff, and it has to be a Brittany approved cuff before I'll turn them loose with their log is my ideal. Making sure that they're taking it correctly and getting a good reading, because it's so important, because I'm basically titrating their meds based upon what they're bringing me from home. Workup is going to also include labs. And as we mentioned earlier, a baseline of labs is never a bad idea. And then again, bringing them back 30 to 60 days after starting that blood pressure medication, making sure that they are doing okay. Do they have side effects? Is it making them have hypotension? Are they dizzy? Is it dehydrating them if I've started something with a diuretic on it? So making sure that is the best and tailored to my patient is going to be the most important thing whenever I'm titrating medication of any kind. I'm going to also get these labs here, but then also I'm going to recheck a CMP and probably a UA about 30 to 60 days after starting the medication. And then you can get a 12-lead EKG baseline, especially if you feel like they've had long-tracked hypertension, or if you hear any changes when they come in. If they have essential hypertension, usually a 12-lead and also an echocardiogram will be covered if warranted. Renal ultrasound, if you feel like their blood pressure is just really resistant, it's not coming down, maybe you've done some changes to their blood pressure, you can consider that. And then also CTA of the chest if indicated. So really there's some options here, making sure their like heart's not enlarged, things like that. So that's going to be important, and it's pretty extensive workup for hypertension. All right, let's take a look here at our first line therapy. Again, lifestyle modifications. Once your patient is diagnosed, and hopefully we've caught it early, we've worked them up, we want to discuss management with our patient. And again, this is going to be based upon what their blood pressure is reading. If it's 170 over 95 all the time, we've passed lifestyle modifications. They need some blood pressure support. But if we're catching them at that, 142 over 89, and they're right there at the borderline, we might be able to implement some lifestyle modifications so that they're on the least most effective dose of medication if it does get there. So again, trying to increase activity, decrease sedentary lifestyle, weight management, smoking cessation, heart healthy diet, minimizing alcohol, and stress reduction. So again, that's our first line therapy. And even if they do leave my office with a blood pressure medication, I still want to educate them on some of this. So again, if they're very overweight, maybe I can start titrating the blood pressure down as they lose the blood pressure medicine down as they lose weight. If their diabetes is out of control, I want to bring their diabetes into control so that, again, maybe they can be on a lesser, more effective dose or most effective dose as time goes. So just some thoughts here. Again, our first line therapy for most things is going to be lifestyle changes. All right, antihypertensive meds here. The decision for antihypertensive medication should not be taken lightly. It will depend on the grade of their blood pressure elevation, also on risk factors such as cardiovascular disease, diabetes. And again, these patients with comorbidities are going to have stricter guidelines, right? If they're under the age of 65, again, I'm really titrating the blood pressure. You can also use the risk calculator I showed y'all. It sometimes will give guidance on blood pressure as well. And then one thing that we always do is if their ASCVD is greater than 10%, then we're going to automatically start blood pressure medication even if they're only at stage 1. So that is one caveat there. And I think about it this way: hypertension, there's a TEN in the middle. So that is one caveat, that if your patient's ASCVD risk is over 10% and they're in that really high risk category, you can consider starting blood pressure medication if they fall into that category. Because again, these comorbidities are going to increase the risk of heart disease, and we really want to try to mitigate that as best as we can. All right, so main drug classes are going to be our ACEs and our ARBs. Remember, these are not safe for pregnancies. Also, angioedema, that's that swelling of the lips and face. With these blood pressure medications, that's a contraindication. Just a reminder, ACEs can cause a dry cough. That is annoying, but it's not really concerning, but we can change them to an ARB. We don't give ACEs and ARBs together. The other options we have are calcium channel blockers. Beta blockers, not usually first line, can make, if your patient has bad asthma or bad diabetes, this may not be the best class for them. But if they're pregnant, it might be a good class for them. So again, all these medications have different options. And again, it's important to try to tailor it and find the best thing for your patient. Thiazide diuretics, again, talking about making sure we're not dehydrating our patients. So if your patient's a roofer out in July in the Texas heat, that might not be the very best medication to give to that patient, because again, it can dehydrate them and make them, have adverse reactions and hypotension. So again, just think about that as you're going through and you're choosing a medication class. But by far, ACEs and ARBs are going to be at the top of our list for most people initial starting of medication. All right. Again, talking about treatment guidelines, JNC8 advises that we start with thiazide diuretics or calcium channel blockers in the African American population, just because they are a little bit more tolerated. Also talking about ACEs and ARBs for just about everybody else. If your patient has CKD, so they have long tract chronic kidney disease, you can do an ACE or an ARB because that is shown to be renal protective. So again, checking if they have protein in their urine is really important. If they have diabetes, you can do that microalbumin and creatinine ratio. That will be really helpful for them, seeing if they are starting to walk towards diabetic nephropathy, and starting them on that for renal protection. So again, taking into account comorbidities, that's what I want you to see off of this slide. All right, so considerations for referrals. So I have this highlighted in red for you. So again, hypertension that's just refractory to medication adjustments. It's just not getting better. We've maybe maxed out the first agent, added on a combo pill of a second, and they're just not. And then, maybe you've even added a third agent. By the time the patient's on three things, it's definitely time for cardiology, maybe sooner if there's other things to consider. Again, cardiac conditions complicate treatment. So if they have some sort of underlying cardiac issue or they've had an event, they should still be followed by cardiology in addition to primary care. Pediatric patients and pregnant patients, again, always co-manage with cardiology and OBGYN if they're pregnant. We want to make sure that these patients are getting the care that they need versus just a primary care NP when they have some of these complicating risk factors here. So just be aware of that. And I'm sure that you all can probably think of some more things too and pop them in the chats of when you would consider a cardiology referral. But again, don't be afraid to make referrals. It's important to provide safe care as a nurse practitioner of when do I end and specialty begins. All right, so our last topic here is going to be diabetes to round out our discussion today of the big three. Of course, you guys know we have type 1 and type 2. Type 1 is that one where those beta cells are destroyed, and basically they're going to be insulin dependent, right? Type 2 is mainly the one we're talking about today. There's a lot of medications for type 2 because type 1 is mainly insulin, but type 2, there's multiple medications. We're going to be talking about some first-line medication agents for our patients with type 2, and so that's what we're really going to focus on today because in primary care, you're going to definitely be seeing probably for every one type 1, you'll probably see 20 type 2s. And that's been in my experience. And type 1 usually has an endocrinologist working with them on board. And so we really want to work with our patients to get them the care that they need. Okay, signs and symptoms of diabetes is increased urination, thirst, thrush, slow wound healing, blurry vision, tiredness, weight loss, and increased hunger. So remember our 3 Ps: polydipsia, polyphagia, polyuria, and then again, visual changes. Of course, slow wound healings could be multiple things. Thrush could be multiple things, but again, just in general, here is your list. To keep it in your differential. And then remember our definitive check for diabetes is going to be that hemoglobin A1C. Now remember, if we see fasting blood sugars on our CMP or BMP, whatever you're drawing, and the fasting blood sugar is up over 100, that should be a little prompt for you to order an A1C on the blood work. If they have blood sugar fasting above 126 on 2 readings, they probably will be classified as diabetic. Also, ideally, we get an A1C on our patients if that fasting blood sugar is over 100. And normal is going to be less than 5.7. And pre-diabetes, they'll cross that threshold at 5.7 to 6.4. And then full-blown diabetes is 6.5 or higher on 2 tests. So, so if they have this, we're going to try to get another one in 3 months and check it. But we're probably going to intervene first, even though they may not have like a full-blown diagnosis. We know they're probably at least pre-diabetic. So just some things for you there. You definitely want to know your A1C numbers and percentages. And remember, that is that average blood sugar over the last 3 months. And there's actually a chart you can Google, and it gives you a correlation. If it's like 5.7, this is what their average blood sugar runs. If it's 7.2, this is what their average blood sugar runs. So you can look that up. And like I said, this is about over 3 months of blood glucose. It gives you that percentage. So that's the average of their blood sugar over the last 3 months. All right, remember guidelines. We have several guidelines for diabetes as well. American Diabetes Association and American Association of Clinical Endocrinology. And also, I just want to put right here for oral medications, MET 1 and 2. And that's just a memory trick that I use of what is going to be my first line medications for the management of type 2 diabetes. So again, I've got lifestyle modifications mentioned for you. Of course, we want our patients to all be doing diet, exercise, and weight loss. Of course, our goal is less than 6.5% for an A1C. I have several patients that once they get started on their diabetic medications, they can get into under, that 7 or 6.5 and kind of get their A1C back marching in the right direction. The one pass I will say here is in our elderly patients. They get a little bit less strict goal for blood sugars. And because, again, we don't want to have them having hypoglycemia, right? Especially if they're like at home and they're living alone and they're a frail elderly patient. So as long as their A1C is that 7.5 to 8.5%, we'll usually kind of let them go on their current regimen. But again, for our younger patients, we want as strict as possible to, really conserve organ function and everything over the long term. First of all, our first line drug after lifestyle modifications, if they're in that pre-diabetic range, that's where we can really try to grab them and get their attention. A lot of times these numbers here, a 6.2, that'll alert your patients and they'll have a stressed out moment in your office and they'll really try to start marching towards making those lifestyle changes there. And if for some reason that they're just not able to get to goal with the lifestyle changes in that area, we can start looking at metformin. And metformin is essentially our first line go-to for type 2 diabetes unless they have some sort of contraindication. So I want you to think about things like, kidney disease, that's more advanced stages, history of like lactic acidosis, those types of things. So if they can't take the metformin, there's some other things, but metformin is usually our first line agent. It's cheap, it's readily available. And who can put in the chats the main thing with metformin, what the number one side effect is? So let me open up the chats. What's the number one side effect with metformin? I will open up the chats and look. Yep, that's right. Absolutely. You guys, y'all are right on it. GI side effects. So absolutely. Now, the way to mitigate that, and it may not completely resolve, but we try to start them out at 500 milligrams daily, just so you know there is an extended release form of this. And I actually prefer that if the patient can tolerate the extended release, because it kind of slows things down a little bit from just running through that GI tract so fast. And I'll start them at 500 milligrams daily with their largest meal of the day. So if it's dinner or whatever, give them that. If they are doing well on that for after a couple of weeks, maybe 4 weeks, whatever, I will let them go up to 1,000 milligrams a day if I think that's warranted. But then the max dose is 2,000 milligrams a day. And again, just like any other medication, I'm going to bring them back in about a month. I'm going to get their initial labs, that A1C, that CMP, and get all that stuff going, and the microalbumin creatinine ratio, whatever it may be. And then I'm going to bring them back in a month and I'm going to recheck a CMP. And then in 3 months, I'm going to check another A1C and see how they're doing. So again, this is going to be our first line Bagwanides class, metformin, first line for most type 2 diabetics. That's our MET part. And then we have 1 and 2. So let's say that our patient either isn't tolerating our metformin or the metformin's just not quite brought them to goal. We are going to look at our next class, and that's GLP-1s, okay? Those have been really rampant in the news. This is what everybody's on for weight loss, Ozempic and Mounjaro and Wegovy, semaglutide, essentially. But there are some other GLP-1s. You see I have them listed here. So Saxenda, Byetta, Trulicity. And again, the FDA has approved Wegovy and Zepbound for weight loss. Again, same thing here, semaglutide and tirzepatide. But the Ozempic and the Mounjaro now we're really trying to reserve for our diabetics. So a lot of times insurance won't cover those for weight loss. So just be aware of that. These can be very expensive, and these are going to be the ones that we give that little shot in the belly once a week, subcutaneously. And these are going to work by slowing gastric emptying. And remember, these GLP-1s have a black box warning for GI disruption and I'm sorry, I just drew a blank on y'all. I was saying, what is it? Delayed gastric emptying, GI, not impaction. and not distress. Um, anyways,
Sorry,
they
I'm
have a,
having a brain fart too.
I know
It's
they have
Monday.
a black box warning. They have a black box warning for basically blocking up the bowels, and they cannot go to the bathroom. Are you guys putting it in here to help me? Slow motility, yes, it's not gastroparesis. Bowel obstruction, that's the word I'm looking for, a bowel obstruction. They have a black box warning for bowel obstruction, and so either partial or complete. And so again, these work by slowing gastric emptying. They have a black box warning for um, bowel obstructions. And so my rule is increase your fiber and water intake. And whatever you would normally eat 50% of that, and then finish your meal a little bit later. And then also, if no bowel movement in 3 days, and they can take Miralax like as needed, but if no bowel movement in 3 days, they need to let me know. We need to get an x-ray of their abdomen and make sure that they're not, really backing way up to where they're going to get a bowel obstruction. If they have like severe symptoms like only watery diarrhea, or a lot of nausea and vomiting, they need to go into the ER because there is a black box warning for this. Also, this contraindication here, I'll just put here, if your history have had of thyroid tumors or pancreatic cancer, they're not a good candidate for this medication. Just FYI there. But again, overall, this is a good drug class. It does bring patients to goal, either used by itself or in combination with metformin. A lot of times we can decrease other medications once they're on this and really rolling. And again, I'll start this really low and go slow. So like 0.25 milligrams of, we'll say, Wegovy, 0.25 milligrams for the first month, bring them back, do a weigh-in. They have met with a dietitian, everything's humming along, they're not having a lot of nausea and vomiting, things like that. Okay, we're going to go to 0.5, we're going to do another check-in, see how you're doing, and what have you lost, how's it working for you, and I'll just really titrate them up really slow like that, like month by month, but to get them rolling on these, because again, due to that black box warning. All right, SGLT2. So remember, MET1, 2 was the mnemonic I gave you at the beginning of this. um, SGLT2, we can't give GLP-1s and SGLT2s together, but GLP-1s, if for some reason they got a bowel obstruction or they have thyroid cancer or they're just not doing good with the GI side effects, we can look at SGLT2. So that's your Farxiga, your Jardiance, your Invokana. That is going to be the one that we give. Now, watch for dehydration. Yeast infections can be rampant in this as well. Also, it promotes the urine to excrete the glucose. So again, think about people who are prone to UTIs, prone to yeast infections. You're going to want to avoid this because diabetes, warm, moist environment, they're already prone to this. This is not going to be a great drug class for them. But just FYI, these have been known to lower the A1C on average by about, almost a point, 0.7%. And also, if your patients have renal failure or are older adults, because this can create some hypoglycemia, just an FYI, really just proceed with cautions, is what I'll say for this. So again, I would say MET1 and MET2. MET1 and 2 is going to be your best mnemonic to remember for first line treatment of diabetes. And then from there, the sky's the limit. There's a whole lot of other drugs. But again, I'm giving you first line stuff today for this lecture. All right, just an idea here. We've talked about how these, disease processes can really impact patients from an entire body standpoint. You guys know there's a lot of complications associated with diabetes. So thinking of everything about their eyes, protection of their kidneys, neuropathy, that's where those nerve fibers get damaged. A lot of times it's not reversible. So you'll see some of your patients that have had this for a long time have like a lot of those numbness and tingling in their foot. Checking and making sure that they, on their monofilament tests, that they can, still have sensation. Talking to them about foot exams, talking to them about whether they see podiatry or you're doing an annual exam, and talking to them about their feet. Very important. Of course, ED. And of course, right here, I've got it. Educating your patients is number one priority, what to expect, signs and symptoms to report. And, let them know that they can call you. They don't have to wait till their next appointment if they're having a big problem to get in there so we can get on top of it in a timely manner. All right, we're just going to tie it all together right here. Of course, all of these things right here with diabetes can increase the risk of hypertension, stroke, and coronary artery disease. Lots of screenings we can do for these patients. Again, they all kind of hold hands, and we want to just make sure that we're not missing anything and we're looking at them completely holistically so that we can give them the best care that we possibly can. Okay, I know that was a lot. That's the main things. We're going to go through some questions with you guys. Y'all have been a great audience so far, and y'all are really, really on it today. And I want you all to put in the answers in the chat. And I also, if y'all have questions that you want, Sam is still with us. So if you all have specific questions or whatever that we can help you with, we're still here on the line with you for a little while. So take advantage of that. Also, just coming back to that slide, in case you were a little bit late today and joining us, we are offering the SurePass package to everyone. If you want to scan this QR code, we just had a 3-day live review this last weekend. It was really good for those of you who got to make it. If you didn't make it this time, you can make it on the next go. You need to get your SurePass, or you can get it just by itself. But I recommend it with the SurePass because there is a pass guarantee. You get access to the Q Bank. Everybody gets access to the Q Bank for 7 days. So if you're taking a test and you need to brush up on some questions, they all have rationales. I would highly recommend that. But you're going to get access to the Q Bank if you get this SurePass. You're going to get access to On Demand. I didn't even mention that earlier, but we have broken down all these topics into bite-size, listening on the go, little videos for you that you can kind of listen to. This is great if you're like in school and you just want some practice with hearing it again, hearing it presented in a little bit different way. So there's On Demand, and then again in SurePass, and then you're also going to get the live review. So this is like the top of the line, creme de la creme package, but it's got that pass guarantee attached to it. Again, I get it. Being a student in school, that's what I love about Archer is that they not only do they try to make things affordable, but they also give a lot of free stuff out. We've just had some giveaways. We'll have some more giveaways coming up, but we want to connect with you. We care about you as a student. So whether or not you buy anything today, I'm not worried about that. I want you to connect on Facebook, Instagram, whatever social media platform that you like. We're putting out questions of the day for free. This webinar today that you're listening to is completely free. We have another one tomorrow. We'll have another one, later in the week or next week. So we have several other things coming up. Sam has one coming up. So just pop in, listen to these webinars as you're going through, because again, this is completely free and we want you to join. We try to give you some nuggets as you're going through, because like we all get it. We're all nurse practitioners on the nurse practitioner team, and we get how stressful it can be as you're transitioning from student into clinical practice. And again, if you have questions that we can help you with, you can email us here. I've got the website up for you. And we'll go ahead and move on and go ahead and take a look at our questions. But again, if you have any other questions, we're here in the chat. Sam will help you. Let's practice right now. In planning pharmacological treatment for a geriatric patient with diabetes, which of the following should be considered? So what you thinking? I'm not going to read you all the answers, but it's there. So I'm going to pull up the chat. Okay. All right. Very good. You guys are on it today. That's right. Oops, sorry. Go back. Whoop. Okay, yes. D is correct. So remember, sulfonylureas can cause falls in the elderly. B is not going to be first line for this patient. And 3, think about hypoglycemia with all that medication on board. So absolutely for that. Okay, let's go ahead and look at this one here. Miss Hadley, a 47-year-old female, comes in to see you for a follow-up 1 month after starting her atorvastatin 40 milligrams, because y'all are great nurse practitioners and you're going to see her in a month. She complains of new onset muscle cramps and dark urine, which lab tests should be ordered along with a comprehensive metabolic panel today. So think about what we want to work her up for and what is going to be needed to work her up for that. Hey, you guys are on it. Absolutely. Very good. This is A, creatine kinase. Anything that's over 5 times the upper limit of normal constitutes an ER visit, right? Creatine kinase is showing muscle breakdown, which could be indicative of rhabdo. And again, if you're not sure and she just calls you, she may send her to the ER. That's not a wrong answer either. Okay, Miss Jones, 35 years old, is 6 weeks pregnant and due to see her OBGYN next week. However, she's in to see you today, and you note that she's on lisinopril. Which hypertension medication could you offer as a safer alternative? Select all that apply. Okay. All right, let's check the chats. Okay, this is a select all that apply. So far we have A and C. Anything else that could be an option? Think about your drug classes. Look at your endings on these. Okay, what is LOL? That's your beta blocker, right? Think about losartan. What is losartan? Is that safe for pregnancy? Think about what else. So what do we talk about in our lecture of what classes are safe versus not for pregnancy? Okay, so this one is ABC. Okay, and I want y'all to think about the alphabet. Okay, if a patient is pregnant, we are going to avoid our ACEs and ARBs. So losartan is an ARB, correct? So we're going to avoid that drug class. So she's already on an ACE inhibitor. We're going to avoid that drug class. So which hypertensive medication could you offer? Select all that apply here. I want you to think about the alphabet. LMN, just like the alphabet. And those are correct medications are labetalol, methyl-dopa, and nifedipine are going to be 3 that we can consider for pregnancy. Okay? And absolutely, Sam. So, yep, new little mama, nifedipine, labetalol, methyl-dopa. However you want to learn it. So, but there's a mnemonic there, LMN, like the alphabet, or new little mama, that you can do to think about safe medications in pregnancy for blood pressure. Okay? All right, let's take a look here. Mr. Kendrick is 72 years old and he comes in with a history of hyperlipidemia for his follow-up visit. And the nurse practitioner auscultates a bruit over the left carotid. What initial imaging are you going to order today for Mr. Kendrick? So what are we thinking? Let's open up the chats. So what are you going to order if you hear a carotid bruit? Very good. That's right. You're going to get an ultrasound. That's right. This is going to help detect plaque within the vessel. And we will get on, we can do other things in cardiology if they're going to see the cardiologist because we have further concerns, and they can get a high quality CT or MRI at that point. But we'll start with an ultrasound, right? All right. 54-year-old male comes into the clinic for his annual wellness visit and lab work. His cholesterol panel is as follows. Total cholesterol 270, triglycerides 692, HDL 54, LDL 143. You're going to prescribe fenofibrate to reduce the triglyceride level and prevent the development of which condition? So think about which one is grossly abnormal. Think about what you want to consider here. So I'm going to give you a hint. Pay close attention to the triglycerides. Okay, very good. That's right. Pancreatitis. Absolutely. When those triglycerides are up over 500, I've already got pancreatitis. kind of on my brain. All right, guys, that's it for today. It's time for us to go. But again, I'll pop that slide right back up for you again. Sam just gave you a good tip. AANP will give you the normal ranges, but ANCC will not. And you all did a great job today. I hope you all will join us again. I'm back in 2 weeks with another lecture at the same time, same place. But we have all kinds of things going on over the next few weeks. So check us out online. You can sign up for our free webinars every week, and we would love to see you again. So yes, and tune into our socials, as Sam said. That's right. That is free content for you to practice. Okay. All right, guys. Well, it's time for us to go.